Welcome, everyone, and thank you for joining us in observance of World AIDS Day today. As we come together to discuss the HIV/AIDS epidemic and future of treatment, prevention, and access to care. My name is Adrianna Boulin. I use the pronoun she and her, and I'm the Community Engagement Manager at the Fenway Institute at Fenway Health. We have a wonderful group of panelists here with us today, and I can't wait to explore the path of getting to zero might look like in the coming years. Before we get going, I also want to mention that today is Giving Tuesday, a global day of giving where people across the world come together to harness the power of philanthropy to make meaningful change in the communities and beyond. The work we do here at Fenway Health and AIDS Action wouldn't be possible without the generosity of our supporters. And I encourage you to make a gift today if you have the means to do so. I'd like to now invite our panelists to introduce themselves. Um, Welcome. Starting with AC. Ken, if you'd like to start, and then we can go back to AC, technical difficulties.
And the joys of modern technology.
Yeah.
Hi, I'm Ken Mayer. I'm Medical Research Director at Fenway and co-director of the Fenway Institute and a professor at Harvard Medical School. I use he, him, his pronouns.
Hi everyone, my name is Alyvia Norris and I use she, her pronouns. I am the Policy and Advocacy Coordinator at Fenway Health and I coordinate our advocacy projects for the Getting to Zero Coalition. Happy to be here.
Thank you all. And we'll give a moment for our third panelist to rejoin us. And while we wait for our panelists, I'll start by sharing with you all what the goal of our panel is for today. The goal is to have a discussion and give a broad overview of the epidemic and provide you all with a look at the work that's been done during the HIV/AIDS crisis, the state of the epidemic present day today, and what the future of treatment, prevention, and access to care might look like in the coming years. Just to a few comments about tech. I invite you all to use the Q&A feature to submit any questions that you have. And I also invite you to use the chat box for any comments or discussion that you'd like to have during the conversation. I'd like to now pass it back to AC for an introduction. Welcome back.
Hi, sorry, not sure what's happening. I'm AC Demidont. I use she, her pronouns. I am an infectious diseases doctor who I am the principal medical scientist for Gilead Sciences. I cover HIV prevention for New England, so I cover Fenway. Prior to this, I ran an LGBT health center in Connecticut, and we had multiple centers in Connecticut. I started it with like a box and a cell phone, and now it's like this big, huge thing. And so I have been working with PrEP for a long, long time, and AIDS activist for a long time as well. So I don't even know if you're hearing any of this, but if you are, that's me.
We hear you loud and clear. Thank you. So we're going to start first by talking about the early days of the HIV/AIDS crisis. And Ken, I wanted to ask if you could speak about the early days of the epidemic and some of the steps that were taken to understand and treat what was once an unknown illness.
Yeah, no, well, it's not always the case that we can date when the public, or at least the medical community, first becomes aware that there's a new problem. Even more so back in the old days, because this is June 1981. And at that time, there's no internet, there's no 24-hour news cycle the same way, so much more limited palette of media. But the CDC has a weekly document called Morbidity and Mortality Weekly Reports. I call it the Women's Wear Daily of Epidemiology. And I was an infectious disease fellow at Brigham and Women's Hospital at the time and working at Fenway, and I would subscribe to it. And I saw this report, and CDC prior to that time in the 70s and 80s never talked about gay people. In fact, the term of art was homosexual, and my eyes widened, my ears picked up, because the CDC was talking about this group of homosexuals in New York and in Los Angeles, and then a month later also in San Francisco, who had these strange illnesses, and they were a variety of different illnesses. And the only thing that was in common was that people who had those illnesses before these reports tended to be people who had immune deficiencies because of chemotherapy, because they had congenital problems. They were born without an intact immune system. And these were people who were previously healthy and then started getting sick with these horrible infections. So we entered this period of time where gay people were front and center in public consciousness. Subsequently, there were reports about people who injected drugs, and there was some knowledge from hepatitis B at that time and hepatitis, what came to be known as hepatitis C, that sex and drugs could transmit viruses. So people thought there might be a new bug, but it took a number of years before we knew that there actually was a new agent, HIV. That period of time, there was lots of misunderstanding, lots of mistrust, lots of stigma, and not the same avenues we have today to at least be able to educate and communicate the same way. So the worst period of time was 1981 to late 1983, when we didn't know what was causing it. There were competing hypotheses, lots of public hysteria, lots of discrimination, stigma against LGBT people, people who injected drugs. There was more awareness that there were other parts of the world getting infected, but really nobody knew what it was and what to do. But by late 83, the agent that caused this, the French first isolated it. Subsequent labs were able to do that. And then by 1985, there was an antibody test that could determine whether somebody was infected or not. But there wasn't really good treatment. So there was a big debate, why test if you're asymptomatic, and what does that mean? So some of our earliest studies at Fenway looked at what this meant. So you have this period, 1985 till 1995, where there are treatments that were tried, but none of them were great. And there was starting to be beginnings of some promise with drugs like AZT, but they were given high doses, single drug, lots of side effects. And it wasn't until 1995, with the advent of protease inhibitors, that there was a combination regimen that really made a difference and started extending life. But the first generation combination regimens also were difficult because they involved lots of pills, lots of side effects. But over the next few years, there really was a revolution in medications where now there are multiple single pill regimens that are extremely well tolerated, and HIV is very different. And one other piece that really has changed the epidemic is the realization that if people take the medication, not only can they lead long and healthy lives, but they're less likely to transmit HIV. In fact, they're virtually not going to transmit HIV. They're taking the medication and their viral load is suppressed. And then the last piece of the puzzle, something that AC is working on a lot, is PrEP, which is a great benefit, so that we can provide people medication to protect themselves against HIV. So it's a whole different ballgame now over these last few decades.
Thank you, Ken. AC, I wanted to ask if you could illustrate for our audience what it felt like and what it looked like to live during this time where either you or someone you love is at risk for becoming HIV positive.
Oh, that's a fantastic and horrible question at the same time. And I think that that's part of what World AIDS Day so much means to me, is that we honor the people who aren't here anymore and fight to make sure that nobody dies of AIDS in the future. Because, part of the things that Ken was talking about was like my adolescence, right? I grew up in Philadelphia, and the only thing you knew about Philadelphia was that you were going to die of AIDS, like Tom Hanks in a movie. And there was a lot of racial issues and all kinds of things in Philadelphia that were really, really scary. But, I think that that's part of the reason why I was always like like growing up, I was kind of like that naughty by nature kind of kid. So, I was always doing stuff that probably I shouldn't have done. And getting myself into situations that I shouldn't have been in. And, you know, I knew that a lot of people did the same things that I did. And so I just happened to be smart enough to be able to go to college and then subsequently go to medical school and take that sort of like feeling of fear. I mean, we were afraid because if you got HIV, you died then. And, or you ended up on some medicine that was probably going to kill you. And, you know, we didn't know what was going to happen. And, you know, certain cities were more, you know, certain populations were had more access. And, you know, if you were a Black person or a trans person, or, you know, it was just challenging for everybody that I knew who was trans in Philadelphia who had HIV. So when I knew the minute that I went to medical school to become an HIV doctor so that I could help medicine understand what it felt like to be somebody like me. And so every day, the job that I do, I am so happy to do the job I do, because I want like no little queer kid who's growing up in this country, or no little trans girl who's growing up in this country to ever have to feel like what I felt growing up, because it sucks. And I want them to know that like there are ways that you don't have to get HIV. And there's a lot of people who died, and we need to honor that. It was a really hard time and scary time, I think, for a lot of us. And people came out of it different ways. You know, I came out of it furious and angry, and I took that anger and focused it on a laser focus of like, I'm going to make sure that I do things to help people with HIV. And even when when we first started talking about PrEP in New York, it was 2009, and I'll never forget, like, people would criticize us and scandalize us and say, oh, you're promoting barebacking and you're promoting this and that. And I would say, honey, barebacking doesn't need any promotion. It's doing just fine. People like it. They love it. It's great. So, you know, it was really scary to grow up like that. And I'm glad that kids have a different option today. And, you know, it's through the work that people like Ken and lots of people around the country have done, who, you know, many of these people didn't even have a skin in the game really when it came to being part of the community, but they worked. And I believe that, you know, PrEP is a life-saving medication for a lot of us, you know, so it was scary to be a parent back then. My mother used to clip newspaper clippings out of the newspaper and send them to me when I was at college. Of course, I went right on and got HIV, you know, I mean, so I didn't listen to a word she said, but, you know, I think that it was scary back then, and it was different. And this COVID thing has sort of like reawakened some of those fears for some of us. And hopefully it's a call to action to people to like remind them.
Thank you, AC. Thank you for sharing. Thank you for sharing. I want to continue on the continuum of from the early days now to where we are today and talk about some of the latest advances in treatment and prevention medications. Also talking about some of our injectable options. Ken, could you speak to some of those advancements?
Sure. Well, I think that the biggest advances were medicines that could be really well tolerated and could be co-formulated together, because the idea of asking somebody to take a single pill a day is certainly a lot easier asked than, you know, people in the bad old days would have to have timers to wake up at middle of the night, you know, because they're told you have to take it every 4 hours or the virus is going to develop resistance. And the new regimens, you know, one of the big revolutionary drugs are called the integrase strand transfer inhibitors, and they've been really important advance because they're so well tolerated and they're so potent, and there's several of them. You know, and as you know, as AC and I mentioned, I mean, PrEP is the other big game changer where people really have a tool where they can express themselves sexually, physically, in ways that make sense for them and their partners, and at the same time protect themselves from becoming infected with HIV. You mentioned injectables, and we're just on the cusp. The first injectable medication, cabotegravir, has been shown to be beneficial for protection, but there are a number of other injectable medications that are coming down the pipe. So there's another target for HIV called the capsid, another part of the virus, and there's a capsid inhibitor that might be able to be an injection every 6 months. That's called lenacapavir. So that's not yet ready for prime time. The injectable cabotegravir, both as a treatment combination and as prevention for PrEP, is close to being FDA approved for prevention, and that will potentially be a game changer. But there are other things. There's less frequent medications, so potentially being able to take a pill once a day, and there's several different versions of tenofovir, the most commonly used PrEP regimen. And then there's on-demand PrEP, which means taking 2 pills within 24 hours of sex and a pill a day for 2 days afterwards, which has been shown to be beneficial for cisgender men who have sex with men, and for other populations we don't have enough data yet. But so what you're hearing is like a variety of different choices, and I think that's so important both for treatment and for prevention, is that to give people options that are congruent with their lives. Is there a side effect that would be a deal breaker for them, or is there a way of taking medicines that makes more sense? So I think this world of new options is really exciting. It's great that we have more to offer people.
Thank you, Ken. And speaking of more options, AC, I was wondering if you could talk more about the next big thing for Gilead and HIV meds, now that Truvada is a generic medication.
Well, Ken kind of already started to allude to, what I am super excited to be, start getting to be a part of a little bit is our, the long-acting injectable agent that is going to be studied. Trials are going to start soon. It was announced that they would add an arm for cisgender women. So that study is in Africa. So it's adding an arm for that long-acting injectable. And what I'm super proud, I went to work at Gilead because it is the most inclusive pharmaceutical company that you could ever work for. I mean, there are 2 out trans women on my team alone, and there are trans people from the leadership to the, and so the nice thing about having trans people on the teams is that we make sure that you're doing stuff right for trans people. And this study is going to include the Mupali Das, who is the person who's running the trial. She has been very intentional about making sure that trans people's voices are heard, that all trans people, trans masculine people, non-binary people, trans feminine people, that all of us are included in this HIV prevention message, because we all many of us like to have sex that puts us at risk, and many of us may even not have a choice about having to have sex that puts us at risk to survive. And so this study, which again will start fairly soon, it will include all trans people. And Gilead has a long history of including trans people in their studies, and trust me, I'm like gentle compared to the other trans woman is a force to be reckoned with, who's on my team, and she is a woman of color, and she will not let a thing go by that that isn't inclusive. So that the next big thing for PrEP, and I mean this drug will be studied in treatment as well, and it really is transformational medication. It will change people's lives. And, you know, we really hope that when we, you know, part of recruitment for trans people is that trans people who are like community leaders, like the mothers of the houses, need to go out and tell your daughters, like, go in there, tell your children to go in there and get in this trial, and it's okay. And there are trans people watching over the trial too, to make sure that they ain't treating you wrong. So, you know, we recruitment will be paramount, but we will, you know, we rely on the communities out there to help us to recruit. I mean, I don't know nothing about Boston. I can line 100 girls up in New York and 100 in Philadelphia, but I don't know nothing about Boston. So I need the girls in Boston to get information and get these kids in who are at risk, to get them on these trials, because we're going to make it so that it's there for you. So I am super excited. That is a game changer. It will change, you know, it is the next big thing. I'm super excited to be a part of it. You know, I mean, part of, so, you know, we'll see what happens. You know, it's going to be exciting.
Thank you, AC. And I want to stay on this topic of advocating for trans people. You know, there's been a lot more public awareness of trans people in pop culture, movies, film, TV. And, you know, have you seen that have an impact in the communities that you work with over time?
Me? Are you talking to me?
Yes.
Okay. You know, I mean, look, I think visibility helps, but we need some of these visible trans girls to get on there and say, like, I used to work the street. Like, I know what it took to get where I am now. And like, I did not wake up with my dress matching the rims on my Porsche in Vanity Fair. Like, I had to work, and that my life may not be the life of many trans people out there. And you know what HIV prevention needs for trans people is like trans people out there who are like influencers telling other trans girls and boys, like, you're at risk, go in there and get tested, you know, find out what your options are. You're going to get your hormones. You can get, you know, and if you're not in a place where you can get hormones, like, help them to underground railroad them to where they can get, you know, hormones. We know that happens all the time. You know, I think the only thing I would say about the problem that sometimes visibility creates is it can increase stigma when the groups fight against it. Like, you know, people chose this past, that's why I'm so proud of Pennsylvania. I'm from Pennsylvania. Pennsylvania has a transgender woman as their, you know, Surgeon General. She has done an amazing job. She threw a lot of BS in Pennsylvania during COVID. She should be the new Surgeon General as far as I'm concerned. But like, that visibility helps, like, that there's people out there doing like jobs that they don't expect us to do as trans people. You know, the only challenge I would say to the visibility is like this idea that we're like going from point A to point B sometimes is really like the narrative that people hear, like, you know, like, I got to be something different than, like, you know, I have to look like Laverne Cox to be like trans. And that's not true, right? Like, it's not true. So I think there's a lot of benefits to visibility. In terms of medicine, I'm not sure that visibility, that they have done enough, the people who are visible have done enough, you know, to make sure that trans girls, like Kim Petras, like some of these people, like, you know, that have had access to care to fight for access to care for trans women and HIV care, as well as like hormone care, surgery care, those kinds of things. Like, I think they should use their privilege. When we don't have much, and if you get some, like, use it to help the rest of the trans girls out there. So, I mean, I think it's good that their visibility, it was not good in terms of, we had more people murdered in the United States this year than we've ever had. And so it is a, like, if they don't uphold laws to protect us and give us healthcare, that visibility puts us in much more danger, in my mind, than not having visibility. So it's got to be like a whole circle, right? And those people with visibility need to use their privilege to help the rest of the people out there. That's my opinion. I don't know, other trans people may have their own opinions, but the visibility is good, but it could be better. It could be utilized better.
Thank you, AC. And you raised the issue of stigma that might come from this visibility. And I wanted to touch base real quick to talk about stigma that we see in HIV and how that may have changed over the years or remained the same or have gotten better. And this is open to anyone on the panel to really touch base on.
I don't know, Liv, you want to start? I'm happy to.
You can start. Thank you.
Yeah, I know. Well, I think that, you know, it's a combination of things going back to the early days of the epidemic. I mean, the groups that were first diagnosed with HIV were groups that were highly stigmatized. And have to recall, we had, you know, not an incompetent, but an equally reactionary administration back when the AIDS epidemic first showed up, compared to this one, the Reagan administration. And they, you know, increased stigma by just refusing to talk about the epidemic, making it seem like something dirty. You know, but there was, you know, homophobia, there was racism from the start, transphobia. These things were all there. You know, and I'm sad to say I don't think they're gone. You know, I think there's been some, you know, your question about visibility, I think it's so important, but you kind of have this, you know, polarization that we see in so many parts of society. So certainly, more than not, younger people are growing up in a world where they understand that, you know, LGBTQIA people exist, and not, you know, may not harbor some of the same inculcated attitudes, but, you know, you have, you know, social structures that are still very non-affirming. Certainly, we have a lot of reason to be scared with the current Supreme Court, you know, with the idea that somehow people having equal civil rights is somehow an affront to somebody's religion, and that should take precedence. So I think that a lot of these things are not necessarily completely out of the picture, the stigma. But I think, you know, that clearly HIV is clearly a different epidemic than it was at the outset back in 1981. But you still have states that criminalize HIV transmission, and there are people in jail still who have been thrown in jail with absolutely no likelihood that they would have transmitted HIV to partners, that they have medical records that they're virally suppressed. And we know that U equals U, that undetectable equals untransmittable, but still the laws have not caught up. And this is not unique to the US, you know, but the US, what we have is, you know, real extremes where we have, you know, in very blue states and in blue cities and in red states, now these policies and laws and attitudes are not highly prevalent, but then you still have other places where there's still an awful lot of work that has to be done.
Thank you, Ken. Liv, can you talk about the Getting to Zero Coalition and some of the efforts and initiatives around how you achieve zero stigma?
Yeah, for sure. So for some background, in 2015, AIDS Action and Fenway Health launched Getting to Zero Massachusetts, which is a statewide coalition of over 40 organizations to achieve the aims of the Getting to Zero initiative. And this initiative is a part of a worldwide movement that's dedicated to ending the HIV epidemic and ensuring that those living with HIV have access to HIV treatment. And so, like Adrianna said, Getting to Zero includes a future where there is zero stigma around HIV, zero new diagnoses, and zero AIDS-related deaths. And one of the ways that we work towards this goal is through advocacy projects like our Activist Academy program. And so Activist Academy is a fellowship program that we started last year, and it was created to recruit, train, and develop community activists in educating community members around HIV prevention and access to care for those living with HIV. And so the Activist Academy equips participants with comprehensive knowledge and tools to advocate on behalf of their communities, mobilize and cultivate other activists in their communities, and educate community members and state officials. So we are currently in our second year of Activist Academy. Our advocacy focuses for this cohort are sexual health education and harm reduction and overdose prevention. The fellows are teamed up in groups of like 5 to 6 people from around the state, and they are placed in teams that center community awareness and their and policy engagement. Sorry about that. And so we have 23 fellows from around the state. The fellows are attending weekly trainings on a variety of topics related to ending the HIV epidemic and tools for advocacy work. And they also are receiving stipends for their participation. And so we have, just to clarify, 4 teams this year: a sex ed policy team, a sex ed community team, a harm reduction policy team, and a harm reduction community team. I'm so excited for all of their projects. And I believe that their work is very intentional in engaging community members in conversations to combat stigmas and expand understanding of what harm reduction or comprehensive medically accurate sex ed can really do for the health and well-being of our communities. So one of our teams, the sex ed community team, is planning a series of webinars to happen early next year. The dates are still to be decided, so you'll have to keep a look at our social media to find out. But they'd like to focus one webinar on sex ed and consent geared towards 15 to 25-year-olds, a second webinar on inclusive language geared towards educators and allies, and a third webinar focused on sex stigma geared towards Black and Indigenous folks and communities of color. And through these webinars, they're hoping to teach educators and allies how to be more inclusive in the language that they're using, discuss healthy relationships, and educate community about the ways that stigma creates barriers to education and barriers to accessing care. And that's just like one of the 4 great projects that our fellows are working on this year.
Thanks for sharing, Liv. It is inspiring to hear about how we are engaging and educating the community. And I reflect on how we've been doing that during this time in support of the response for COVID-19. And I think about some of the biggest barriers to engaging populations who are most at risk for COVID-19, Black and Indigenous people of color. And one of the biggest barriers to supporting them and advocating for their health is trust. And what I've found successful in building trust is a couple things. And I think it's important to note. First is listening to the community, actively listening to the community, and acknowledging the historical experiences that are still very active and present today and continue to perpetuate negative health outcomes that we see in these communities. And what it takes is the courage to confront the uncomfortable conversations, the uncomfortable constructs, the uncomfortable systems that we're used to, and to commit to name and act on the systemic change that needs to happen. That is what is required to create that trust. And I think it's a model that can be used for trust in a medical infrastructure system. And so when we think about HIV treatment and prevention research, how has that helped us in our approach and response to COVID-19?
Well, Adrianna, you now have 2 hats, as you know, and I don't know if everybody in the audience is aware, but you know, one of the strange outgrowths, benefits is sort of a strange word to say, but the HIV response to the HIV epidemic created a cadre of centers around the country and around the world that learned how to do HIV research. And learning how to do HIV research is more than just knowing how to give somebody an injection or a bunch of pills and say, see you later. because as Adrianna said, there's lots of reasons for legacies of mistrust of federally funded research sponsored by governments that are on one hand saying we have to deal with this pandemic, on the other hand, not dealing with the lives of the people who are most seriously affected. Very early in the this pandemic, it's all sort of 2 degrees of Tony Fauci. And so Dr. Fauci and his advisor said, gee, we put a lot of money into funding these units that not only have trained, clinicians, trained research assistants, research pharmacists, but they have community educators and they have community advisory boards. And they've been in dialogue with the community for the last few decades. And sometimes it's not always been easy, or they've really had to hear the voice of the community. And although the communities are not 100% identical, we don't try to enroll a lot of 70 and 80-year-olds into HIV research necessarily. But on the other hand, certainly in terms of the race, ethnicity, and some of the lived experiences, life circumstances of people, it's very much the same people and a lot of the same community gatekeepers, whether it's the faith community or interested professionals in the Black community or other communities of color. So what Dr. Fauci asked was that these research units that were focusing on HIV clinical trials could then be repurposed and also do COVID research. And Adrianna has really led a program for us at Fenway to engage the community around COVID-19 and to start facilitating conversations with key stakeholders such as the Boston Black COVID Coalition. And the advantage about being a community agency and about being here for a while is that it's not like, where the hell did you people come from? But on the other hand, there's certainly things to be talking about priorities and resources and how we approach things. And it's, I think, been a productive and constructive dialogue that's been developed.
Thank you, Ken. Liv, can you share how the COVID-19 pandemic has changed how we deliver messaging to the community about safer sex and all the populations that we serve?
Yeah, for sure. Well, to be quite honest, outreach has been one of my biggest challenges this year. So I definitely would love to hear if any of you have had different experiences. But from my experience, outreach has felt pretty limited, but also very engaging in my creative brain to figure out how we can reach people where they are now. And I feel like overall that is what people are doing. Folks from all organizations are just doing their best to meet people where they are. Online, for example, I've seen that there's been a lot of social media engagement. I saw that Fenway Health started using TikTok, and our sexual health team made an Instagram at Your Health Boston, and they started doing simple things like recreating funny SpongeBob memes to let people know that they have free condoms right now and they can get them to them. So I just feel like those things are so instrumental right now in just making sure that we're getting the message out. I've also done a lot more virtual outreach to my community-based orgs across the state, and just have really expanded my contact list. The Healthy Youth Coalition recently held a virtual lobby day that was really well attended. And at the end, they facilitated a group action to contact legislators, encouraging them to support the bill. There's been so many webinars and trainings, and a lot of these conferences are also making recordings of their virtual events available online afterwards so that people can go back and check them out, which is great because not everyone has the ability or the financial means to attend conferences in person. And also screen fatigue is real, so it's nice to be able to stop and catch up later when you need to. And some things that I've noticed in person in my own community is that there are some folks who organize like a community fridge in Jamaica Plain, which from my understanding is like an open space where people can visit anytime to grab food or donate food. So to summarize, in terms of reaching folks, while it does feel a little limiting at times, I've seen that a lot of people are getting really creative with like their online platforms and in how they utilize the neighborhood space that we do have.
Thank you, Liv. You started by saying it was limited, and that felt like abundance. So
it feels a little limited, but it's also like so expansive. It's limited from what we used to do, but it's expansive to a new world.
Yeah, and it's allowed us to innovate and find like new ways to reach people, which is awesome. So thank you for sharing that. I want to close with a question to really open up to anyone that wants to answer, everyone, if you'd like to contribute. We've talked a lot about how the HIV epidemic has helped us learn about our approach and response to COVID-19. And, you know, I want to bring it back, and I'm curious to know about in what ways do we think COVID-19 might help shape how we approach infectious disease moving forward?
Well, you know, we've been going for a few decades and we still don't have an HIV vaccine. And, you know, so I think, you know, they're different viruses, and HIV is a hard beast, but it certainly does speak to when something's prioritized, one can move quickly. And I think that's one lesson, is about mobilization of resources. But I think, as Liv was alluding to, I think, you know, um, we'll have to figure out what the right balance is when we get our lives back, in terms of how much time we want to spend on screens. But as somebody who's spent a lot of time commuting, commuting between Boston and Providence, commuting to various meetings, you know, there's something a little bit liberating to, you know, to not have to spend so much time in Logan and, you know, dealing with bad weather, and you know, um, to show up at a meeting, you know, and spend more time commuting to the meeting than you're spending at the meeting. So I think they're going to be, you know, the world is not going to be the same after this. Hopefully, the world will be better in some ways, and you know, at the very least, hopefully, public realizes that we're all very interconnected, and these things can really tip the world, society over very quickly. So hopefully that means that there'll be an investment in public health, and understanding what are the drivers, you know, and a lot of the drivers of who's getting sick are people who are crowded, people who are poor, people who have fewer options for sheltering in place. So hopefully attending to those issues will also be a priority as we move out of this pandemic over the next year or so.
I'm gonna just put a plug in for, you know, new voices, right? When I was young, I was right before I transitioned, went through this whole like leather thing, and it was right when PrEP was getting, and I was Mr. Eagle New York City, and I got some IML, and you get up on stage and they didn't want you talking about barebacking, and like I had this one moment where you had a platform to like say something different and do something different, and you were a different voice, and I was young, and my career, like, it didn't make any difference what I said. And I would go upstairs and nobody was using condoms in, you know, these leather events. And you know, you bring the reality to medicine, and you bring the reality out. And I think that's what these platforms, what COVID had to do for like my old organization, is us old people had no idea how to use these like social media platforms to reach people. So we finally had to actually listen to young people. And young people today have ideas that will blow you away if you listen to them. They are creative, they are skilled, they know how to reach the community in a way that I didn't know how to do. And I've been like out in the community compared to a lot of people in medicine. So I think that is one of the things that COVID, how it will affect HIV prevention at least, is we now like have had to listen to young people's voices and new voices about how to navigate this like internet, social media world, TikTok, you know, using like social media influencers to get people to do stuff, all of those kinds of things. COVID forced us to do it because we couldn't do the traditional way that we used to do HIV prevention anymore, like sitting in front of somebody and giving them a test. And the people that I know who figured out how to do it the best were, you know, 20 somethings. They had these ideas of how to navigate the world of the internet that because that's all they've known it since they were kids. I mean, we didn't even have email when I went to college. So I mean, like, as many times we like to, us older people like to hang on, like we are, and we're here as like guides, but like COVID has forced people like me and many of us, and a lot of people to like listen to young people's voices, and also to be activists again. People forgot how to be activists. They really did. So I like that about what has happened is, for HIV prevention, we're going to be able to utilize young people's voices much more than maybe we have in the past.
Thank you. I like that call to action, AC. And in the spirit of a call to action, we have a question both for you and Ken, asking if you could advise the new administration about one action step they could take from a policy perspective, what it would be.
Oh my God, Ken, I already said, make Rachel Levine the Surgeon General. I'm telling you right now, it would change the world for transgender people. She's qualified, she's smart, she's navigated COVID very well. She is, she's a pediatrician, a psychiatrist, like that. A lot of that I feel like that would be one thing that Joe Biden could do, but and there are so many policies that need changed. I mean, yeah, I don't know where even to begin. So that's all I'm gonna say is, that's my plug for her. If she would even want it, I don't know. That's all I can say.
Well, she sounds great, and seems like a very concrete and something very actionable. I'd probably go for sort of something a little global, which is that, although I don't think that health disparities are the only part of the story in terms of why, despite having wonderful medications for treatment for prevention, not everybody's benefiting, but it's certainly a big part of the story, and it's one of the more actionable parts of the story. And I think it's, ridiculous that we've not been able to get the benefits of the ACA available to all Americans, and then to figure out where are there various donut holes and other problems that, create economic disincentives for people to be accessing medication. And again, the medicines are great, but the pills don't take themselves, and and they need to be done in a context. So it's not just about getting people medication; it's getting people care and affirming environments. So it's a big ticket item, but again, we need to invest in our country and the people who live in the country, and these are just simple, humane steps. I mean, if you compare the current death rate from COVID-19 in Germany to the U.S., if you take it on a population basis, because it's a smaller country, but we still have 5 times the death rate, in a comparably developed country. It helps to have a woman scientist at the helm of government, but also is really important to note that there's a social safety net. Doesn't mean that there aren't poor people, and it doesn't mean that there aren't people who are marginalized in the country, but at least you don't have these unethical extremes in the society. So I think the administration can focus on trying to address that both medically and in terms of the social service network. That would be my wish.
Thank you, Ken. We have a question for you, AC. If you can share any challenges that you may have encountered as a provider doing outreach in communities to populations that are reluctant and against the LGBTQ community, if you have any of those experiences.
I mean, all of my experiences were that in training. I mean, I went to medical school I know I don't look this old, but I mean, I went to medical school. There were no, it was like, even like gay people didn't exist, sort of like they were there, but they were stealth in medicine. But if you were like me, you showed up like me, you were like, I had a blonde mohawk when I showed up for my infectious disease fellowship in, Hershey, Pennsylvania, and they were not ready. So, I think, I think medical education in general needs to do better about teaching the cultures of the people that they're going to take care of, whether it's, all minority cultures, not just like they shouldn't learn medical education just be like about diseases. It should be about people and like their cultures and why they may or may not listen to you and how to get, and why they may or not even trust you when they get to see you. I think overcoming the barriers, for me, I just kept showing up, and I say this every year that I wake up. I always stay up till 12:05 on World AIDS Day, and I say to myself when I go to bed, you made it to another World AIDS Day, because I would bet you that there were many people in my neighborhood who never thought I would make it to this World AIDS Day. So I think having cultural humility is really, really important way to overcome a lot of the barriers that exist for marginalized communities. And I hate that word, marginalized communities, but like, we are marginalized. And also encouraging more people like us to go into fields where we can have a seat at the table and actually make decisions. Like, don't just hire a Black person to be a part of your, executive suite to like check the box off to have a Black person there and then ignore everything they say. I love I forget what she's the chief diversity officer for Target. If you ever listen to her, she's amazing. And she says, don't sprinkle your authenticity on people right when you get there. Like, sit back, watch it, scope out the room. And if you're a marginalized person, you know how to scope the room out to see if it's safe. And then once people know that you're good at your job, then you tell them, like, why don't you have any makeup here for Black women if you're a Black woman? And I think, but we need to encourage people to, number one, go into fields, encourage organizations to give us a seat at the table, and then listen to us when we get to at the table about the communities that we come from, because that's the only way to overcome those barriers, is for people to walk into an office and see somebody that looks like them. It is the only way that they will know that it's okay to be there. I mean, I was in the hospital last week, believe it or not. And, I didn't see any other trans people in that hospital, right? And so now I know the hospitals, so they, they're going to be extra good with me because they know I'll like put a CHRO complaint against them. But like, I think the fact is that we need visibility in that sense, and we need to have a seat at the table. All of that overcomes barriers. And I've been lucky enough to have some of those seats at tables. And when I've had the seats at the tables, I've been that one that everyone's like rolling their eyes, like, oh my God, here she goes again. Why is she talking about all this? And just keep fighting, because you woke up today, girl. And if you are a marginalized person in this country and you've battled through and you're my age and up and you're still alive, and you're a Black trans woman and you're over 40 and you're still alive, like, you weren't supposed to be. Like, averages would say that you weren't supposed to be. So keep fighting, keep like your voice being heard, and eventually stuff will change. It will change if we keep talking, keep fighting. Look, there's lots of diversity on this panel right now. It makes me so happy to see that, that's great. So that's what I would say about that. I don't know if that makes any sense.
Thank you, AC. It made perfect sense, and it was so moving. And I would love to land it at, we talk about this fight that we're doing, and I want to talk about what gives you hope for the future. And I invite you all the panelists, to respond. What gives you hope to fight for the future?
You and Liv.
Yeah, it's true.
You and Liv give me hope for the future. And Jonathan, and when I see young queer kids out there making zines and standing up and saying, I'm from Philadelphia, sorry, we curse. We're not taking this. And when I was in Waterbury, Connecticut, and I got like in my car, and like there was a Black Lives Matter like march, and I was like in the car, and I was just watching it, and I was like brought to tears because it was all young people, and I was like, finally, like young people are doing this. Like that gives me hope, because I'm tired. Ken, you got to be tired, honey. We're tired. I am tired. And so that's what gives me hope for the future. When I see you not only just like up on your phone, like on Tinder or whatever, like on Grindr, like when I see you all like doing it, that's what gives me hope for the future. It gives me more hope than I've ever had for this country.
Yeah, I totally agree. I mean, I think working with young people, and these days pretty much everybody I work with is younger than me. I don't feel tired. I feel energized by working with people who are younger and seeing their idealism and their vision, and feeling like maybe they'll get it right. Because certainly we've got a long way to go, and it feels like, it's like Sisyphus and the boulder up the hill. In the last 4 or 5 years, the boulders really come crashing down. But there's lots of great energy and lots of wonderful young people to move things forward. The other thing I'd say is that science gives me hope. And I knew we were in trouble from the day that I heard the term alternative facts, and we're going to have to, battle for the minds and the hearts of the rest of the country to move forward. But the thing about science is ultimately you can't bullshit science, and excuse my language, and science has made great progress. And I think there's more things that lie ahead with new technologies, with information technology, with biotechnology, that will get us even further. So I think that plus the energy and the idealism of youth is really exciting.
I would say that I have 2 things that give me hope. One would be similar to what AC said, like the local activists on the ground leading the charge. They are paving the way, and they're doing such great work in their own communities. And I love seeing the work that they're doing. The people who are on their own, not backed by organizations, just doing this every day because they care and they want to see a difference. And then also something that my supervisor says to me is that people have a better understanding of what public health, a lot of people have a better understanding of what public health means now that we've been experiencing this pandemic. And that will give us a lot of space to maximize our discussions on a variety of public health issues and how they're also interconnected. So talking about how housing is a public health issue, food insecurity is a public health issue, stigma is a public health issue. And being able to make those connections, I think, with people in my community is going to give me a lot of hope.
Thank you all. Thank you all for this time with us on the panel. Thank you all out there for joining us, for your questions. This was really special. Thank you for observing this day, and let's keep the work going. Let's continue fighting together, and let's all have hope. Thank you for joining us, and have a great rest of your day.
Thank you.
Thank you.